who is also the chair of the organizing committee of this masterclass, will present the topic of tips and tricks for polypectomy. Dr. Nuthapong has his pediatric GI training in Thailand and from Louisiana State University in the USA. Currently, he is an associate professor at Chiang Mai University in Thailand. So please welcome Dr. Nuthapong Ukarapol to the stage again.
Okay, good morning, everybody, and once again, welcome to the endoscopy workshop. And first of all, I would like to emphasize once again about the adequate efficacy of bowel preparation. That is one of the most key success factor for colonoscopy, particularly for a pediatric colonoscopy. And before we performing polypectomy, don't forget to review current medication, particularly those affect blood clot like anticoagulants or antiplatelets. And we'll recommend lower setting for the right side of the colon. I mean the power of the coagulation current, because of the right side of the colon is the colonic wall is thinner compared to the left side of the colon. And when we apply the electrical power, right now we recommend the blended current more than exclusive cutting setting, because of the risk of bleeding will be lower when you apply the coagulation force while doing the polypectomy. And the techniques depend on the size of the polyp. About the technique, if the polyp size is less than 3 millimeters, I would recommend that cold biopsy forceps could be applied. But if the polyp size is in between 3 to 8 millimeters, you may decide to use either hot or cold snaring. But the cold snaring is more advisable in the right side of the colon because of the risk of the perforation is higher in the right side of the colon. But definitely, if the polyp size is more than is larger than 8 millimeters, we're gonna apply the hot snaring for the polypectomy. And we have a little trick for you. If you apply the cold snaring, we will use the push and cut technique. But if you use the hot snaring, we will recommend you to lift it up a little bit and cut the polyp. We learned from our experience and published this data years ago that our pediatric patient, the mean age of the pediatric chronic polyp is around 6.5 years old. This is comparable to those reported from European country. And of course, a lower GI hemorrhage is the most presenting symptom of the children with the chronic polyp, followed by some maybe present with the diarrhea and maybe confused with the cosmiology, and almost 1/5 of the patient had iron deficiency, chronic iron deficiency anemia, and 20% of the patient may present with the chronic abdominal pain. I have one patient with a severe protein-losing enteropathy because of the polyposis coli. The patient has many polyps in the colon and cause the bleeding and anemia, and also hypoalbuminemia. The average diameter of the polyp that we measure in our study is about 15 millimeters, and most of them, 84%, is the pedunculated type. And importantly, about 20% or 18.75%, the patient have more than 5 polyps in the colon, and 13% of them found in the right side of the colon, and 6% they have pan-colonic polyps. So from this study, we strongly recommend to do full colonoscopy in every child, investigating for the colonic polyp. Of course, every procedure has a risk. There have been many reports regarding polypectomy complication, but I pick up two large reports from the US, one from the north of the America, and another one from Florida state. But most of them is in adult study. The serious adverse event for polypectomy is about 0.36% to 1.22%. And the most common complication after polypectomy is the bleeding, both immediate post-polypectomy bleeding and delayed polypectomy bleeding. And also there's some report of the transmural burn. Some may call post-polypectomy coagulation syndrome. The patient may present with a fever after the polypectomy and lower abdominal pain, maybe have a sign of localized tenderness and rebound tenderness positive. And the CBC will show leukocytosis. And in that study, very fortunate that all the patients responded well with the antibiotic therapy. But some of the patients may have the silent or perforation after polypectomy, and also they may have a snare entrapment or ensnare bowel, which required surgery. To prevent the bleeding complication, which is the most common complication for the polypectomy, I will introduce you two methods. The first one is the prophylactic clips, and the second one is the detachable snare, or we well know as an endoloop. Concerning the risk of the bleeding, the factor that determine the risk, particularly for the immediate post-polypectomy bleeding risk, we can categorize into 3 groups. The first one is the techniques factors. The second one is the polyp itself, and the last one is the host factors. From these 3 factors, the technical factor is the most important to determine or to risk the immediate post-polypectomy, particularly when we accidental or inadvertent cold snare polypectomy. Before we apply the electrical current, this will cause the post-polypectomy bleeding immediately after you cut the polyp out. And another thing is, but I think this is in the past, but during this era, we have, with the advent of the technology, we don't use any more only cutting setting for polypectomy. And for the polyp itself, the large size of the polyp size is greater than 1 centimeter is risky for the developed bleeding after post-polypectomy. And for the host factor, this is based on the adult study that the patient that has CKD or chronic kidney disease and cardiovascular disease may have a risk for developing post-polypectomy bleeding. This may be because of platelet dysfunction of the chronic kidney disease, or maybe because of the drug that used to prevent the thromboembolic event in cardiovascular disease. But for the delayed post-polypectomy bleeding, the incidence is less common than immediate post-polypectomy bleeding. But polyp size, once again, is the most important factor that determines the risk of the delayed post-polypectomy bleeding. About the detachable snare or endoloop and epinephrine injection to prevent the post-polypectomy bleeding. There's an RCT study from Korea, and I think that I think there is no, this study show no significant difference between the endoloop and epinephrine injection to prevent compared to the control. But in the subgroup analysis, when the polyp size is greater than 2 centimeter, endoloop and epinephrine injection can prevent post-polypectomy bleeding. However, endoloop may not guarantee 100% to prevent the post-polypectomy bleeding. This study showed that there may be failure of the endoloop, and some of the patients may develop immediate post-polypectomy after application of the endoloop, and also delay post-polypectomy bleeding. And some may have failure to apply the endoloop into the polyp. And one of the most serious complication is the loop entanglement with the snare, that maybe we need to do some more surgery to remove it out. And this is the reason. There's many reasons for the endoloop failure. One of the most common reason for the endoloop failure is narrow of the colonic lumen. You know, because of the endoloop, it's very flexible, and if it doesn't like the snare, that you can use the colonic wall to help to expand the diameter of the snare loop. But for the endoloop, it's very difficult, particularly in the narrow colonic lumen. Such as in the sigmoid colon, that there's very limited space. And some of the endoloop may slip out after the polypectomy, particularly when we apply the endoloop in a very short stalk of the polyp. And when you use the endoloop in a very thin stalk, sometimes when you try to tighten the endoloop to prevent the bleeding, that you will cut the stalk accidentally or inadvertent and cause the post-polypectomy bleeding. So you have to be careful about the choice when you want to prevent the post-polypectomy bleeding by using the detachable snare. Don't use it in very thin stalk of the polyp. But for the thin stalk, I will recommend that we may change the strategy to use the prophylactic clip. That would be more easier and maybe more safer. And the last one is the polyp entrapment with the endoloop. And for the clips, there is a study, an RCT study, that prophylactic clip is advantage, particularly for the immediate post-polypectomy bleeding, especially the grade 3 and 4 post-polypectomy bleeding. And also the prophylactic clip is helpful to prevent the bleeding as an overall. But for the subgroup of the delayed post-polypectomy bleeding, it shows no advantage by using the prophylactic clip for prophylaxis, the bleeding. This may be because of the number of the delayed post-polypectomy bleeding. The prevalence is very small, very small. So the comparison by statistic significant may not reach the statistical significance. And what if we combine the epinephrine with the clip? We use the two combination. Is it helpful, or it add more advantage by using the clip alone? This study showed that epinephrine injection doesn't add any benefit to when you use a clip alone. And what about when we compare between clips and endoloop? Which one is better? This is a head-to-head study an RCT to compare prophylactic clip and endoloop, and we find that this study found that there is no statistical significant difference between two methods. However, your choice depends on your experiences and availability and the cost. And of course, as I talked earlier and mentioned earlier, the stock size is one of the that determined one of the factor that affect our decision to use either one, clips or endoloop. And finally, I would like to talk about the drug that we have to consider before we gonna do the polypectomy, particularly anticoagulant and antiplatelet. And first of all, we have to tabulate 2x2 table between the risk of the bleeding and the risk of the developing of the thrombotic event if we have to stop the anticoagulant and antiplatelet. And if the risk of the cardiovascular is very low, regardless of the bleeding risk, we don't need to stop any anticoagulant. If the bleeding rate is very low, you don't need to stop warfarin or any pellet, antiplatelet before doing the endoscopy. But if the risk, if the cardiovascular risk if the bleeding risk is very high, as in this slide, and the cardiovascular risk is also high, we recommend to discontinue anticoagulant, and maybe we will use the bridging therapy. So switch the warfarin to heparin or low molecular weight heparin to shorten the half-life of the anticoagulant, and we can stop the anticoagulant that very short period of time to prevent the developing of the thromboembolic event. And for the antiplatelet, if the thrombotic event risk is very high and the bleeding risk is very high too, they recommend to stop or discontinue the clopidogrel or thienopyridine, which is one of the antiplatelet, before 5 days before doing the polypectomy, or switch to the standard dose of the heparin. This application is mainly studied in adult, and it may not perfectly fit with our pediatric population because of our kids do not experience the same cardiovascular risk as an adult. So you have to consider our unique condition in children, like Kawasaki disease, or the patient that have the post-bolus thoracic shunt, post-surgery, post-cardiac surgery. This is have not been mentioned in this American Society of Gastroenterology and Endoscopy guideline. I think this is just a guideline, but it may not perfectly fit to recommend in our children and our kids. In my experience, we don't have this much to be considered because of the cardiovascular risk or the patient that on anticoagulant and antiplatelet is very few. So thank you very much for your attention, and I am happy to answer your question.